for diabetes, but found to be helpful in weight loss. And because they are not going to cause a low blood sugar, because like I said, it will stimulate the pancreas to release insulin if necessary, that, you know, they start seeing those types of benefits. And so then you can enlarge the population, the indicated population. So for me, my approach to a new patient, so if I have a new patient who's new to me and I can see they're obviously obese, because I have a way that I approach every new patient, once I have gone through my kind of systematic approach, I will say, you know, at some point during our conversation, I will ask that patient, what have your previous doctors, what's been the previous discussion about your weight? And they'll answer that however they answer that. And depending on how much time we've already spent, like how complicated their history already is, I will say, well, you know, what are your thoughts about weight management medications or weight management surgery? And they'll give their answer. And then I will say, well, at a future visit, then we can talk about this in more detail. Because and a new patient visit includes, you know, I'm gonna check your blood work. So if you end up having like frank type 2 diabetes or something like that, then that, you know, that's a separate conversation that's specific, and then that could be just part of the treatment plan. But I, you know, will not generally go into the depth of those medications at that first visit. I will bring it up, you know, especially if someone says, I'm open. You know, if they say I'm not open, I'm like, oh, you know, okay. You know, but if they say they're open to it, then I will have them come back so we can have a more specific conversation about what the options are. And I think that's why these clinics and these online, that's, you know, kind of, you know, in the private, I think that's why they are doing really, really well. Because sometimes, even though you should have a very open relationship with your doctor, some patients may feel kind of embarrassed, especially if your doctor doesn't bring it up. If I have a heavy patient, and I'm heavy, if I have a heavy patient, I will say, what are you doing about your weight? And they might say, what you doing, Dr. Tisdale? You know, but I feel like we should be asking. Right. I mean, and like I said, I've had patients who are 400 plus, and I'll ask them, and they will say nothing. My doctor has never said anything. And I think that is a negligence of care. Yeah. So you know, I'm not a fan of these online or even some of these in-person clinics. I have a patient, she's young, and she came to me as a new patient, and she was already had like her 6-month membership. I said, well, when that runs out, I can do this. And so I just saw her last week, and she's like, they started taking my insurance. And I'm like, that's interesting. And she would probably let them know, I won't need to be coming, you know what I mean? But now they take her insurance. And so I'm like, well, you know, I wonder what the new catch is going to be, because a lot of times these clinics will say, oh, well, we're going to give you B12 shots too. Oral B12 is just as absorbed as injection B12. So, you know, there's always some kind of catch, because they're getting you for the visit, they're getting you because they also don't take your insurance, they're getting you a lot of different ways to get that extra money when you can just get the prescription from your doctor. So the BMI, while we still use it because it is a number system, it really is, in my opinion, not the end-all best way to try to manage your weight or to look at your health in general. It's a piece because it's a tangible number. And so just for reference, a BMI between 25 and 29.9 is overweight. A BMI greater than 30 is obese. And then once you go beyond 30, you know, 30 to 35 and 35 to 40, you have different classes of obesity. So, you know, I just want to, because I think a lot of people, you know, patients will ask me, well, what should my weight be? What's my BMI? And they may have a BMI that puts them in the overweight range, but have a completely healthy appearing stature, and would not be someone that I would advise taking a chronic weight management medication. So don't just look at your BMI. So yes, it is a shot, but these sub-Q needles, folks maybe have had to take them for Lovenox, for, if they've had blood clots, or gotten them in the hospital. These sub-Q needles are so baby fine and short that I have not had a patient ever come back and say, I just can't get myself to shot. Pretty fast. So like I said, so we'll stick with Ozempic. Now, I don't know if you're familiar with Mounjaro, and then, so Ozempic and Mounjaro are for the diabetics, and Wegovy and Zepbound are for overweight, obese patients. And so in studies, Mounjaro was clearly outpaced Ozempic and Wegovy. But I will have patients start to see some of the appetite suppression and some pounds even with those starting doses, but certainly more as we go on this. And I've had patients, get to the max dose and they recognize that like the appetite suppression isn't there as much, and they're having to pay more attention to what they eat, and so again, with anything, when your body is naive to something, you will tend to have sometimes a very sensitive or over response. But with time, we call it tachyphylaxis. You can become tolerant. So you still are going to reach a point potentially where you have to be more mindful of what you're doing, not doing. I think a good rate of loss is about 2 pounds, 2 to 3 pounds a week. But I've had a few patients lose quite a bit more than that. And again, like I said, because weight is something that society is so fixed on, it can be hard for someone who is been desperate to lose weight and see pounds coming off, hard for them to appreciate if we think they're losing the weight too fast. So it's kind of like, I'm not going to deny a patient a prescription just because I feel the weight loss is too. Because again, that's me having to be careful about introducing my own personal, opinions, and trying to just keep it strictly for what it's for. But I personally think if you're losing, going from dose to dose, 2 to 3 pounds a week, I think that's totally fine. And I've had patients where I said, I think you're kind of stalling. I feel like we should maybe try the Mounjaro or the Zepbound. And I have some patients who they're like, I know, I like it, I don't want to mess with it. And I'm like, okay. But their weight loss has plateaued. Some prescription plans, I have a few patients that will want it through mail order, which can make it kind of tricky because you are expected to kind of go up on the dose each month. But generally, if you're getting it from your local pharmacy, it's going to be a box of 4 doses dispensed at a time. And so I've had folks certainly say after, like, maybe not the first dose, I can't really say I've seen it with the first dose, but definitely when I have them come back for usually about that 6-week mark, they've noticed a difference. And so that's when I would want to go up on the dose. Once if I feel like you understood, what I need you to report, what to expect, before I will prescribe the next dose, at a minimum, we're gonna make a phone call to make sure you're tolerating it, and if you've had a positive response, and also ask, do you want to go up on the next dose? But I don't expect patients to see me every time they need a refill or need to go up on the dose. As long as we have the communication, the documentation that things are going well, you're tolerating it, then I'm fine with refilling it, giving you a higher dose. I had a few patients, 2 that I can think of right offhand that just didn't tolerate the side effects. So it wasn't that they were not losing weight, they just didn't get to that point because they didn't tolerate the side effects. The most severe side effect that I've had a patient experience is the intractable vomiting and abdominal pain. I had a patient tell me they'd read about gut paralysis, and I guess that is obstruction. And what I said to that patient was, you don't just develop spontaneous obstruction. Generally, there have been some signs to indicate that you're putting stuff in and nothing's coming out, and you're having kind of like a buildup of some level of discomfort. And so, once you've gotten to the point of an obstruction, it is unlikely that there was nothing that was not reportable. Like you were experiencing something that, in the context of taking a medication like this, we would have thought about, well, something is going on. We need to investigate why your gut is, not moving things forward. But I have not had any of my patients have any issues with obstruction. So it's weekly. Now, some of the older GLP-1s, because they're all older ones, like Victoza, Trulicity, Budurion, they're older GLP-1s, and those were daily. These that are popular right now are weekly. And there are like 2 starting doses. I often will start my patients at the second of the starting doses. So like Ozempic starts off at like 0.25 and 0.5. I'll often start patients at 0.5 versus 0.25 unless I already know them to have had like bypass surgery, or they have a really sensitive stomach. They already have like, gastroparesis, which means their stomach already moves slow. But I'll generally start at 0.5, and then each month, if you're tolerating it, go up to the next step. Overactive thyroid, underactive thyroid, those are patients that certainly could be suitable candidates for the GLP-1s. Medullary thyroid cancer is one that is not. This is sometimes a little hard to get the history on. Is someone with a family history or personal history of medullary thyroid cancer? Not all thyroid cancers, just this medullary thyroid cancer, that would rule you out as someone who could use the GLP-1s. That's a special type of endocrine cancer. Papillary thyroid cancer is not an absolute contraindication. I'm just trying to think of the patients that I have. I've had a few patients who I have felt that through the course of their GLP-1 treatment, their thyroid has become enlarged. And so, we've done some additional assessments on that. We haven't had any cancer yet. But it's important to say, with all medications, new ones that we've been using for 50 years, 100 years, we use medications based on what we know now. And what we know now includes retrospective studies too. So 70 years from now, there may be people saying, oh, we would never use a GLP-1. Or we would never use Ozempic. We would never use Wegovy. So everything you take with some risk, whether it's been on the market 100 years or 5 years. I think that's important to say too. We prescribe based on the safety, the evidence that we have at this point. And that includes looking retrospectively too. So all the people that were in studies, the animals that were in studies, they're still, being assessed. And then whatever people report now that they may be experiencing with the medications. People tend to lose hair just like after weight management surgery, that lack of protein, those vitamin deficiencies. So it's not that the medication causes hair loss, it's that nutritional deficit causes hair loss. So being mindful of your protein and your vitamins, because these medications, we start at 1 dose, and as the patient tolerates, we go up a dose pretty much every month. And so when food is moving slower through your stomach, it's just kind of sitting there. You have to be mindful of those cues that I'm feeling full, because that food, if it is in your stomach and your stomach it has a big bolus of food there, that food's gonna wanna come back up if you keep trying to put more food in. So people who have a lot of vomiting, some nausea, because sometimes nausea is just you feeling a little bloated because you're full. But folks who are having a lot of vomiting, the movement that slows through the rest of the gastrointestinal tract can cause constipation. So you really need to keep hydrated, because if there's no fluid to move that stool through, it's already moving slow, it can just stop moving. Cost depends on your insurance coverage. And some of these medications will have coupons. Medicare does not honor coupons. So if you're on Medicare, unfortunately, you do not qualify for coupons. But people with private insurance, if there are coupons, that's an avenue to maybe get a reduced price. But ultimately, usually coupons have an expiration date. So you still have to navigate what it may cost you after your coupon expires. And so essentially it boils down to what your insurance covers. And that is, when I first started prescribing, that was like the bigger barrier, was folks' insurance just didn't cover it. And they'll ask if we can write a letter stressing why. And that's just not something that I can do for everybody, so because your letter, your insurance, your employer has picked that insurance to cover probably thousands of employees. So your letter, unless you get everybody to write that same letter, is generally not going to make your employer change the whole plan. But I have seen, just over the course of, I'm gonna say, I've probably been prescribing this for about a year, or maybe longer, I don't know. I have seen more plans pick them up, and patients that I thought it would, they thought it wouldn't be covered, or folks, a lot of times you get it kicked back because someone's not a type 2 diabetic. I'm seeing a lot more insurance companies cover it just for the chronic weight management, which is nice. I would say that menopause is not a reason to not manage weight. Does menopause impact a woman's ability to maintain weight? It probably does. And the reason I say probably and does is because with menopause, essentially menopause is just the decline in estrogen, which leads to the decline in ovulation and the loss of a period for a year. 1 year of no vaginal bleeding, that is menopause. But we know with menopause, some women will have a menopause that is seamless. Some women will have a menopause that is partially destructive to their mood, their sleeping, and so all of that can certainly cause changes within your life that could lead to weight gain. For me, when women come to me asking, complaining about something or saying they're experiencing something, and then they say, could it be my hormones? I'm not a gynecologist, but my general approach is it's possible, but whether or not you are in menopause is not going to change my management. And so if it's not going to change my management, I can tell you if you're in menopause, have you had a period in a year? So if you haven't had a period in a year, you're in menopause. So for me to check your hormones is not clinically valuable to me, because it's not going to change how I manage you. Because depending on what the symptom is, and depending on what your history is, you're either a candidate for hormone replacement therapy, or you're not. You're a candidate for non-hormonal therapy, or you're not. So knowing what your FH, LS, LH, that doesn't really, it's not valuable to me. Gynecologists, I'm sure they check them way more than internists do, because that's their specialty. And I think the expectation of checking those values is much higher, especially maybe if someone is, younger and clearly at a premenopausal age, maybe having fertility issues. Those are clinically valuable, but somebody wouldn't be seeing me for those issues. So that's why when women ask me, could this be menopause, perimenopause, could this be hormonal, unless I think it's frankly due to something else in the pituitary axis, I don't check estrogen and progesterone because it's not going to change my management approach. People will do all kinds of things for 30 days and lose weight. And then they stop that thing, that regimen, and the weight comes back. So these medications are intended to be used long-term. They're not intended to get you to a goal weight and then stopped. I have patients who have reached have had really great results and we have not maxed out the dose, and so we decide to just hold them where they are. They're everywhere, Facebook, social media, you see stars, celebrities using them for kind of like a quick turnaround. That's really not the intended use, and that is what complicates like supply as well. But these are intended to be chronically used because most people who are obese, it's not because they eat a pound of bacon and a gallon of ice cream. It is often been a lifelong issue, whether they have had spurts where they are exercising or really restricting themselves. Most of their life they have been obese. So if you introduce a treatment that has this layered effect of mechanisms, and you take that away and you continue life as you have been, you're gonna gain that weight back. The other ways that the GLP-1s help is when diabetics will say, I don't know why my blood sugar is so high, I only ate, but your liver is a source of sugar as well. So it's not always just what you eat, your liver produces sugar. So the GLP-1s reduce the amount of sugar that the liver produces, and when necessary, they stimulate the pancreas to release insulin. So those last two are why GLP-1s are very helpful in the treatment of diabetics. And why this class of medications has become a very good step before insulin is because if you know much about type 2 diabetes, type 2 diabetics have been a type 2 diabetic and just didn't know it.
Right.
And then they'll have some routine blood work and their blood sugar meets the criteria. And the criteria for type 2 diabetes is a random blood sugar of 200, doesn't matter when you last ate, or a blood sugar of 126 or higher if you're on an empty stomach. And generally an empty stomach is you had dinner and now you're the next day before you've eaten and your blood sugar is 126 or higher. That meets the criteria for a type 2 diabetic. So what often leads to a delayed diagnosis of type 2 diabetes is the pancreas being able to compensate. So you may have had blood work, or people often send patients blood work that says, your blood sugar was a little high, but compensated, which means that other test, the A1C, is still less than 6.5. So I'll say you're pre-diabetic. You're not diabetic, you're pre-diabetic. And that essentially means your body, your pancreas, is still compensating for those elevated blood sugars whenever they occur. If they occur after a meal, or if they occur in the middle of the night, your pancreas is still able to receive that signal and pump out insulin. When your pancreas is no longer able to compensate by pumping out additional insulin, that's when you have those labs that show you're frankly a type 2 diabetic. So bariatric surgery is long been underutilized, and a lot of times when patients talk to me or I approach them about weight loss surgery, it's because they don't think they're big enough. So I believe the cutoffs for BMI are like 35, 35, and then under 35 if you have chronic health conditions. So when you think about a BMI of 35, that is probably not much bigger than most of us.
Yeah.
You know what I mean? And if I were seeing you, I probably wouldn't suggest right off surgery, but I am really amazed at the number of patients that I see that are probably with BMIs 45, 50, and their previous doctors have not even spoken to them about weight management whatsoever. They haven't even brought up their weight. And I think that's a number of reasons. Sometimes people, doctors, because we're human too, we don't think that's a sensitive subject. So we may wait for a patient to bring their weight up. Obesity is linked to almost everything. Heart disease, breast cancer, arthritis, so obesity is on everybody's list of risk factors. And again, as a clinician and someone who is obese myself, I can tell you that while it can be a potential risk factor, certainly everyone who is classified as obese does not have run the gamut of all of those diseases, So when we think about our overall health, it's also important to consider, okay, this is my BMI, this is my weight. Do I also have hypertension? Do I have diabetes or prediabetes? Do I have high cholesterol? Because in a number of cases, the answer will be no. And so that too will impact how we approach if this is a patient that wants to focus on their weight management.